Welcome to This Explainer. Today, we're going to unpack a genuinely fascinating historical puzzle. We're looking at how a singular and, let's be honest, highly controversial 19th century medical doctrine actually survived its founder to become a globally regulated modern tradition. We'll be tracing the wild evolution of homeopathy, starting from Samuel Hahnemann's original personal system all the way through a really complex web of contemporary practice right up to the strict demands of 21st century scientific scrutiny.
Here is our agenda for today. 1. After Hahnemann. 2. Early pioneers. 3. Global spread. 4. Modern interpretations. 5. Current position. And 6. Appraising the evidence. Let's get right into it.
Section 1. After Hahnemann, the inciting incident.
So, picture this. It's 1843, and Samuel Hahnemann has just died. At this point, his ideas could have easily just faded into obscurity, right? Just another eccentric 19th century medical footnote. His primary text, the Organon, was obviously central to his work, but honestly, a single book just isn't enough to sustain a global movement. It was really up to his followers to step up to the plate and systemize his personal teachings into a lasting tradition of texts, tools, and practices.
And if we trace this timeline, you see a really distinct thread. Right after his death, boom, there is this massive expansion through Europe and America in the 1840s to 1860s. But then we hit the 1900s. As conventional biomedicine started standardizing its licensing, the movement faced some intense professional tensions and, frankly, an uneven decline. Which brings us all the way to the modern era, the renewed interest, the intense regulatory scrutiny, and the heavy integration debates we're seeing in the 21st century.
Section 2. Early pioneers. Building the tools.
To pull off that kind of massive early expansion, his followers literally had to become architects. Guys like Bunninghausen, Hering, and Kent didn't just practice homeopathy, they built its actual infrastructure. Clemens von Bunninghausen, for example, created these early analytical repertories, basically a rigorous ordered system for mapping out symptom relationships to help with deep clinical reasoning. Then you have Constantine Hering, who drove the American expansion and famously came up with the direction of cure. And later, James Tyler Kent designed this massive integrated reference text. He emphasized a strict cognitive hierarchy, putting mental signs way above physical ones. But a quick note here, Kent is a historical interpreter. We really shouldn't confuse his views with Hahnemann's original foundational texts.
Section 3. Global and institutional spread. Mechanisms of transmission.
Now, abstract ideas in heavy reference books don't just cross borders magically on their own. The movement actually relied on 5 concrete pillars to go global. First, texts had to be rapidly translated from German into English, French, and Spanish. Second, professional journals started sparking this whole culture of peer discussion. Third, new societies and associations popped up to standardize practitioner ethics. Fourth, it naturally evolved from quiet personal apprenticeships into dedicated colleges and hospitals where they were seeing a high volume of patients. And the fifth pillar underpinning the whole shebang? Specialized pharmacies. They guaranteed that you could actually go out and get standard, commercialized remedies anywhere.
Section 4. Modern interpretations. Contemporary frameworks.
Fast forward to today, and practitioners are still attempting to organize all this historical remedy knowledge in completely new ways. George Vithelkus, for instance, codified classical training globally with a framework he called levels of health. But others took some pretty radical taxonomic approaches. Rajan Sankaran grouped remedies into biological kingdoms, like mineral, plant, and animal, using a sensation approach. Jan Schulten went as far as linking the chemical periodic table directly to human psychological archetypes, and Jeremy Scher focused heavily on standardizing modern proving designs. Now, as someone learning about this, you've got to separate these fascinating internal method descriptions from external empirical outcomes. They might be great for pattern recognition, but they run a very real risk of speculative overinterpretation.
Section 5. Current global position. Contrasting regulations. So, with centuries of complex history behind it, how do modern governments actually handle this practice? Well, it is absolutely not a one-size-fits-all model. Take India. There, homeopathy is highly formalized within state-supported institutions under the Ministry of Ayush, and they have an extensive national education and research network. But contrast that directly with the United Kingdom. Over there, the National Health Service generally states that there is no good quality evidence for its efficacy, and because of that, they do not routinely fund it in primary care. And you see this crazy global variance everywhere. Over in the United States, the FDA subjects these products to strict drug requirements, and they explicitly warn that they are not approved for therapeutic use. They focus heavily on contamination and labeling. But cross the border into Canada, and they're regulated under specialized natural health product frameworks.
Meanwhile, in Malaysia, the Ministry of Health oversees it under a distinct traditional and complementary medicine scope, focusing a lot more on practitioner registration and strict legal boundaries.
Section 6. Appraising the Evidence, Research Literacy.
Which brings us directly into the crosshairs of modern scientific scrutiny. If you truly want to understand this topic today, you have to transition from just reading historical philosophy to rigorously reading actual clinical research.
To be responsible here, and to avoid both uncritical promotion and dismissive oversimplification, we have to navigate 5 distinct types of research. First, randomized clinical trials to test outcomes under highly controlled conditions. Second, observational studies to see what actually happens out in the real world. Third, systematic reviews to pool all that data together. But you also have to look at basic science, which explores the debated plausibility of high dilutions. And finally, health services research, which evaluates public access and safety. You really have to know what constitutes robust data versus what is still conceptual uncertainty.
I want you to walk away from this with a genuine superpower, a 5-step appraisal framework. Next time you read a study, start by identifying the exact therapeutic claim. Is it just historical philosophy, or is it a massive efficacy claim? 2, check the source. Are you looking at an unreviewed textbook or a peer-reviewed medical journal? 3, dig into the evidence. Look for sample size and bias. 4, check safety. Could relying on this delay vital conventional medical care? And 5, consider practice. How should a responsible professional communicate this to a patient while maintaining true, transparent, informed consent?
As we wrap up, I want to leave you with one final thought to apply those new appraisal skills to. When you look at this incredibly complex web of 19th century pioneers, sprawling global institutions, and modern scientific trials, ask yourself this: how do we responsibly navigate the intersection of patient choice, centuries of historical tradition, and the strict demands of evidence-based safety and public funding in modern healthcare? It's a huge puzzle. Keep asking the tough questions.